Thank you for your kind introduction. It's my privilege to talk about VT ablation in advanced heart failure. And this is my disclosure. And I'm an electrophysiologist and I'm not an expert in heart failure treatment. So I have to update my knowledge about heart failure, especially advanced heart failure. So I first think about the advanced heart failure as a symptomatic near functional class 3 or 4 heart failure symptom. But in fact, there is a well-written guideline about the stage of heart failure. And as you know, stage A is an risk for heart failure, and stage B, pre-heart failure with structural heart disease or evidence of filling pressure or risk factors. And we are caring for symptomatic heart failure, and those patients are classified as stage 3, and advanced heart failure is defined as marked heart failure that interfere with daily life and the recurrent hospitalization despite attempt to optimize guideline-directed medical treatment. But there is a wide spectrum of stage near functional class 3 or 4 heart failure patient, and near class 4 patient can be subclassified by intermediate profile from 1, critical cardiogenic shock and inotropic dependent patient, or 4, resting symptom and home on oral therapy. And their functional class 3 can be subdivided into intermediate 5 to 7 patients, and generally electrophysiologist cares for intermediate profile for advanced near class 3 symptom without need for heart failure admission. And there is arrhythmic modifier A, and some advanced heart failure patient has recurrent sustained VTO of VF requiring intervention or ICD therapy. And there is some concern about the LVAD implantation in patients with significant ventricular arrhythmia, and the data shows that the LVAD implant is safe and effective in those patients, and because LVAD LV unloading, there is a decrease of ventricular arrhythmia. And there is some definition guideline for advanced chronic heart failure, and they are functional class of 4 symptom, and there must have a severe cardiac dysfunction defined as a low ejection fraction and severe impairment of functional capacity, such as inability to exercise or VO2 max less than 12 ml per kg per minute, or recurrent hospitalization over the last 6 months. What is the clinical features of advanced heart failure? Those patients have repeated hospitalization due to heart failure or renal dysfunction, or they have cardiac cachexia, and they have a hypertension, and they are intolerant to a RAS inhibitor or beta blocker, and they have very symptomatic at last, and there is hyponatremia, and they require very high dose of furosemide. And they also, if they have a frequent ICD shock, it is also a feature of advanced heart failure. Heart Failure Society updated the advanced chronic heart failure guideline, and they included isolated RV failure or non-operable severe valve abnormality or congenital abnormality, as well as reduced LV ejection fraction. And they also included malignant arrhythmia requiring 1 unplanned visit or hospitalization over the last 12 months, as well as pulmonary or systemic congestion or low cardiac symptom. And we all know that this whole new treatment can improve the outcomes of heart failure treatment, and selected patients are needed for device therapy depending on the EKG characteristics or heart failure symptom. And if the patient advanced to a refractory stage, they require MCS or transplantation. There are wide spectrum of advanced heart failure patient, and in less advanced patient, VT can occur and they can be treated as a cath ablation. But in a far advanced heart failure patient, the efficacy and safety of a VT ablation remains unknown. Over the last 20 years, there is a huge, tremendous progress of cath ablation of VT, and we understand better about the VT circuit, and we can visualize the substrate defined as a bicardiac scar by delayed enhancement, and we can measure wall thickness by CT scan. And those imaging studies can help to understand the VT circuit. And we can integrate pre-procedural cardiac CT or MRI imaging. And we can acquire multiple data using a multi-electrode catheter, so we can map the LV within less than 30 minutes. And we also map the epicardial surface of the LV by epicardial puncture. And we also map the LV septum using a cardiac vein mapping. And we have a very good irrigation catheter. And you can see the LV lateral wall, and the wave goes from the below to the upside and goes down to, and it can show the figure of a re-entry in the post-MI patient. And this is my case, and he has a huge anterior wall MI and aneurysm in the anterior wall. And you can see the apical aneurysm using ICE. And you can see the low voltage area in the apical aneurysm, and pink dot denotes the ablation lesion. And if the patient has a coronary artery disease and present with a monomorphic ventricular tachycardia, if the presentation is the first time, we can choose the cath ablation if the patient LV ejection is preserved greater than 40%, or we can implant ICD, or we can administer amiodarone. If the patient presents with sustained monomorphic VT in a patient with a pre-existing ICD, if the first episode is without use of amiodarone, we can administer amiodarone or sorol or cath ablation. Or if the patient has received amiodarone, we should undergo cath ablation. And as you know, the VANISH trial shows that the cath ablation in a patient with ICD and prior MI and a VT event, the cath ablation decreased the VT recurrence and decreased appropriate ICD shock, and the cath ablation does not increase the mortality rate compared to escalated therapy. And the first-line therapy of cath ablation in a wide spectrum of cardiomyopathy shows that the concurrent implantation of ICD and cath ablation decrease the VT recurrence and can improve. We think it can improve the quality of life in those patients. And another study shows that the ICD patient with recurrent ICD shock, they randomized to ablation therapy versus a standard of care, and the ablation therapy decreased the composite of death from any cause of worsening heart failure that lead to hospitalization. But in fact, in those trials, there are a very small number of advanced heart failure, so we should very careful in selecting best patient for cath ablation, especially in advanced heart failure patient. And the most important thing is that the cath ablation can delay the first event of VT, and it also decrease the VT burden. It can decrease the VT burden about 20% compared to escalated antiarrhythmic drug therapy. And most important thing is cath ablation can decrease the shock-treated VT event about 40% decrease. It's just simple cases, 69-year-old man, prior MI, and the freeze-over ejection fraction, and no need for revascularization, and he had right bundle branch block inferior axis VT, and we mapped the LV, and we find the critical circuit in the anterior wall, and we can terminate the VT within seconds, and he had no VT episode. So in those patients with coronary artery disease, if the patient has symptomatic sustained monomorphic VT, like just last case, and he had a recurrent shock, cath ablation is recommended as a class 1 indication. But in non-ischemic heart disease, cath ablation is recommended as a class 2A indication because the non-ischemic cardiomyopathy patient has a very diverse cause of substrate, so it is quite difficult, and the cath ablation, the procedure itself can precipitate the heart failure aggravation. The electrical storm is defined as more than 3 episodes of a VT, and there is a wide variety of causes. And if the patient presents with polymorphic VT, we should consider ischemia and heart failure and PVC or long QT syndrome. And if we treat all things together, and if those patients has presented with a recurrent polymorphic ventricular arrhythmia, we need mechanical circulatory support as well as a deep sedation. And I will skip this information. And the second case is a 52-year-old man with coronary artery disease and atrial flutter, and he underwent mitral valve repair and CABG surgery. And after several days later, he had a recurrent ventricular fibrillation requiring multiple hundreds of defibrillation for ventricular fibrillation. And he underwent urgent coronary revascularization in the obtuse marginal branch. And we mapped the ventricular fibrillation. And we found this single PVC that initiated the ventricular fibrillation. And we ablated and eliminated this PVC, and he remained alive until now for 10 years without need for ICD, and his ejection fraction is greater than 40 to 50%. So if the patient presents with electrical storm, we need cath ablation as well as a best hemodynamic stabilization and medical treatment. But we should pay attention to the severity of a heart failure patient. Those patients who underwent VT ablation has a severe LV dysfunction, and about 10% of patients has acute hemodynamic decompensation during the procedure. If this happens, the mortality rate is about 40% in 1 year. So it is really, really important to prevent acute heart failure decompensation after cath ablation. And the cath ablation of VT in a patient with advanced heart failure has early mortality rate of 5%. It's really high, and is far greater than the CABG surgery or mitral valve surgery. And it's associated with the risk factor of acute mortality is COPD, elderly ischemic cardiomyopathy, advanced heart failure, ejection fraction less than 25, or electrical storm. If the point is greater than 17 or 18, the mortality rate is really, really high. And we can do a cath ablation in stage 4 heart failure with acceptable range of complication, but you should pay attention to this mortality. In hospital mortality is around 20%, and 1 year mortality is 50%. So if those patients does not have exit plans like MCS or heart transplantation, we should really, really be careful in selecting those patients who need VF ablation. And if the patient needs cardiopulmonary support during the VT ablation, the mortality rate is really high, like 70%. I don't know whether we need VT ablation in those patients because we can cure the VF, but the patient dies due to cardiogenic shock or multi-organ failure. I will skip this information. And if the patient has LVAD, even though those patient has hemodynamic stabilization, there occurs the early ventricular arrhythmia up to 25%. And if the patient presents with electrical storm after LVAD, the mortality rate is quite high. And there are many causes of VT, like reentry or bundle branch reentry or focal mechanism. And we can treat those ventricular arrhythmia in patients with LVAD, but the complication rate is up to 10%. And if the patient presents with electrical storm after LVAD, in patients with LVAD, the mortality rate is very high. And those patients with prior failed ventricular ablation, the risk is very high. So one clinical trial going to randomize the intraoperative VT ablation as well as LVAD versus medical treatment to evaluate the occurrence of a ventricular arrhythmia after LVAD. Should we provide a service for VT ablation in advanced heart failure? The answer is I don't know, but I think it would be more safe and effective if we provide VT ablation in less advanced heart failure. VT ablation in advanced heart failure patient is a higher risk procedure that is comparable to or worse than the open heart surgery. And the heart team approach would be the best approach, and we should optimize and stabilize the heart failure status. We should access to vasculature with zero complication, and we need more than 2 EP specialists during the procedure, and we should not induce very aggressively because it can decompensate heart failure. And hemodynamics and the fluid balance and pain control is absolutely needed to prevent heart failure aggravation. And if the patient needs ECMO, we should access to the vasculature with zero complication, and we need post-procedural expert care by an advanced heart failure team. Thank you for your attention.